Good evening, everyone. Welcome to this Wednesday's FRCS teaching. I'm Firas Arnaout, be modulating tonight, and we have other mentors, Abdullah and Kashif. The presenter tonight is Nikki Walsh. She's a surgeon from the Lake District. She has a lot of experience with the exam. And she's gonna present one of the critical conditions subjects. This is very important, being discussed in BOA and instructional courses and elsewhere, and it is a hot topic at the moment. So it's very important exam topic, and Nikki has kindly offered to cover this tonight. As you all guys know, if any questions are welcome, please raise the hand symbol next to your name. Or write in the chat box, and we'll try to answer your questions the best of our knowledge. And at the end of this, CPD certificates can be available. If someone needs one, please get in touch with me. There will be short Viva session after this. People who are interested, please let me know as soon as possible if you're interested. There might not be many questions tonight. Thank you, everyone, and over to Nikki.
Thanks, Firas. As Firas has introduced me, I'm Nikki Walsh, and I'm a specialty doctor at the Royal Lancaster Infirmary. I trained in Australia, so I've got a little bit of experience of being on a training scheme, and then I've come back to the UK. The reason I wanted to cover this issue was that I passed my exam last year, but having gone to a few conferences, it's occurred to me that things have changed with the diagnosis of necrotizing fasciitis, and it's now a critical condition, and there are things that I think we need to know as FRCS candidates. So I'll try and cover some of that in the lecture. What I will say is that there's not a lot of photography around about necrotizing fasciitis, probably because it happens so rapidly and you don't always have patient consent to use the images. So the images I've used are from my acknowledgements, but be aware they could come up in exams. So my acknowledgements are these, and one is Mr. Banachwich, who did a presentation at the BOA instructional course in Manchester in January of this year, and in combination with him was Mr. Birender Kapoor, who works in Liverpool. He was also part of the same group, but Mr. Kapoor has also put on the BOA website 2 lectures on necrotizing fasciitis. So if you go into training and resources, orthopedic podcasts, and then scroll down to screencasts, you will find necrotizing fasciitis, amongst other things. But necrotizing fasciitis is in there, and he's done a very, very good lecture on it. So these are the necrotizing conditions that you need to be aware of. So, you know, we've always thought of necrotizing fasciitis as a single condition caused by Clostridia, but in fact, there are different causes. The most common one is necrotizing fasciitis, which is polymicrobial. Necrotizing fasciitis group A strep, which is the most rapid and destructive of all of them. Then you have other things like streptococcal myositis, clostridial gas gangrene, non-clostridial gas gangrene, and staphylococcal tropical myositis. So if you look at that photo, I have another photo from a different angle that we're going to come up later with. But I can tell you that's a guy that scratched his finger on a rusty nail, and we'll see what happened to him later. So why are we bothered? Well, look at the mortality rates. If you have necrotizing fasciitis, polymicrobial, your mortality rate is going to be 30 to 50%. You've got group A strep, it's up to 100%. The others are not as virulent, but certainly strep myositis, clostridial gas gangrene, non-clostridial gas gangrene, and staph tropical myositis have lower mortality rates. So for the purposes of this lecture, I'm going to focus on the first two, which we can deal with. So how do we classify it? And the reason I've put this in is that, you know, classification systems are not really necessarily required in the exam. But we were asked this a lot of the time in the instructional course. So I've put it in there because I think the main difference needs to be between the polymicrobial and the group A strep. Because the group A strep is going to kill you within about 12 hours. So the classification is types 1 to 4. It depends on the causative organism. Type 2 is the classic group A strep infection with rapid progression and high mortality. So the type 1, which is the polymicrobial, it's going to be the majority of your cases. It's going to be a combination of aerobic and anaerobic species. Most commonly will be E. coli, Pseudomonas, and Bacteroides. There's an average of 4 organisms isolated in these cases, but we don't know if they're all pathogenic. It's more common in immunocompromised patients, and it can start as an indolent infection. The mean time to surgery is more than 100 hours due to delayed diagnosis, and the outcome is dependent on the comorbidities. The mortality of a polymicrobial NEC Fas is between 30 and 50%. Type 2, this is our classic NEC Fas, right? It's group A strep, it can be Staph aureus. It's about 20% of cases. It's very, very aggressive when it presents. It produces exotoxins causing a toxic shock syndrome, and the mortality is between 50 and 100%. And in addition to this, you know, this will be something like, so I've had a recent case, which I've not put the photographs in because I've not got permission, but a gentleman that was on chemotherapy, he got a thorn scratch on his finger. And he came into emergency within 12 hours with a little bit of redness around it. So they gave him some amoxicillin and sent him home. Within 12 hours, he was back with cellulitis above the elbow, quite unwell, necrosis in his hand. And as we tried to discuss with plastic surgeons and things like that, the erythema progressed gradually up over his deltoid and onto his chest wall. And in fact, he died. How quickly a group A strep can manifest. So the type 3 is more of the marine type of organisms. The Vibrio ones are probably the most common, and it tends to be wound contamination with seawater or bracken water, which is like, you know, a dam or a lake or something like that. And it's about 25% of cases. The mortality is a little bit lower, and that's 30 to 40%. So we have a bit more time with that. Type 4 is a fungal infection. It affects mainly immunocompromised patients. So it's mainly a candida. It can occur after trauma. You can get fungal isolates from all of your specimens for NEC Fas, but it doesn't mean they're the causative organism. Type 4 is the causative organism. So it's probably more common in things like HIV. And the mortality, again, is 40 to 60%. So what's happening? Well, I can tell you that the incidence in the UK is increasing. And in fact, it's doubled in the last decade. We've got an increase in the rate of diagnosis of necrotizing fasciitis, and we've also got an increase in the mortality rate. So we need to kind of address this. So what can we look at? Well, from an epidemiology point of view, it's quite rare. It's only 13 or 14 cases per million of the population. Males are about 2/3 more infected than females, and it tends to be immunocompromised patients. So people with diabetes, decompensated alcoholic liver disease, steroids, drug users, people that are undergoing chemotherapy, radiotherapy. The exception being the group A strep, which can affect anybody at all. Why do they kill us? Well, they affect mainly immunocompromised patients because they have an inherent lack of response to the infection. One of the problems is that they cause early superficial ischemia. So they thrombose the subcutaneous vessels and the lymphatics. The fascia is relatively avascular anyway, but they block off any blood supply to that as well. So you develop these large areas of ischemia. You get this rapid spread because the zone of infection and the method of spread means that the antibiotics you prescribe cannot reach all of the areas of bacterial presence. They spread horizontally, so they move horizontally along the fascial planes rather than a vertical spread down through the tissues. And particularly with the group A, they produce exotoxins and endotoxins, which multiplies their virulence. On top of all of that, we have no experience with it. You know, there's a lack of exposure of teaching and training of GPs, physicians, and surgeons. You know, even as a surgeon, they expect you to see 2 or 3 cases of this within your whole surgical training. I think I've seen 3, and I'm an orthopedic surgeon. So how many would a GP see? I'm not sure. The other problem is they mimic cellulitis. They look like cellulitis. So the average time to surgery is over 100 hours because the diagnosis is delayed. There is some evidence that shows if we can debride it within less than 24 hours, the outcome would be improved. But we don't have, you know, we're not exposed to it. We don't really know how to diagnose it and how to differentiate it between cellulitis. So what can we do? So some of the early clinical features that would push you more towards a necrotizing fasciitis rather than a cellulitis would be these. And one of them is disproportionate pain, which is the most significant finding. So your pain is going to be well out of control of your initial assessment. So say, I'm going to show you a picture soon of a guy with a foot injury, but he had pain all the way up to his knee and his thigh. That would be disproportionate. Exquisite tenderness, so it's deep tenderness. So say you have a problem in the hand, but you're finding exquisite tenderness in the forearm compartment. That may be a sign. Erythema that is spreading, so you lose skin turgor and you get delayed capillary refill and you get swelling. Some of the late features can be crepitus, which is estimated to be in around 25% of cases. You get blisters, you get hemorrhagic bullae, you get anesthesia of the skin, and you get necrosis of the skin. So this is the LRINEC score. Now, it's never been validated, but it does help us a little bit in trying to diagnose who we're going to debride. So there's a lot of weighting on the CRP. So if you look at the CRP, less than 150, more than 150, you're looking at 0 to 4, right? Your white cell count is there, your HB is there, your creatinine is there, and your glucose is there. So the maximum you can score is 13. If it's 8, it's highly suggestive of a necrotizing fasciitis rather than a cellulitis. If it's above 6, you need to be suspicious. If it's below 6, it doesn't exclude it completely because it's not a validated score. And the problem with it is that the CRP has a high weighting, but if you've got decompensated alcoholic liver disease, your CRP may not rise. Is there any role for imaging? So we could do an X-ray, which may show gas gangrene. We could do a CT. The advantage of doing a CT is that it may show fat stranding and it may show a collection, but you shouldn't delay your initial debridement waiting for a CT. If you're going to do a CT looking for a collection, do your first debridement, go back, do your CT, looking for a collection so you know where to go next time, but don't delay your initial debridement. So what's the treatment? You need an MDT input, right? You need broad spectrum antibiotics, usually meropenem and clindamycin, but you'll need to discuss with your microbiology department. You need early ICU admission. These patients will need vasopressors, they'll need support of their hypothermia, and they need level 1 support. You need to monitor their shock. IV immunoglobulins for group A strep has been debated. So the NICE guidelines say for severe infections unresponsive to other treatment, they may be used, but they are expensive. If you are lucky enough to have a hyperbaric oxygen chamber in your trust, you can certainly use it, but the studies are 50-50. So some say benefit and some say no benefit. The mainstay of treatment is going to be your radical excisional debridement with antibiotics, and you need frequent reevaluation. Your surgical debridement, you need a clear plan. You need to plan what you're going to do. So you need to ensure that you've got access to every possible site. So I'm going to show you a picture of a foot where we debrided all the way up to the hip. So you need to make sure these areas are exposed. You start with zone 1. You try and find the normal tissue, which is zone 3. You send samples from each zone. You debride zone 2. You must take all the fascia from zone 2, and you need at least 10 millimeters margin of healthy fascia. You need to go back and repeat it in 12 to 24 hours. So how are you going to decide what to debride? Well, part of it will be your LRINEC score to see whether you're actually going to debride them or not. Then it's going to be a clinical indication of where the tenderness is. Then you're going to take the patient to theatre, and this is what you're looking at. So your zone 1 is going to be necrotic tissue, gangrene, everything else. Your zone 2, you might have some erythema, you might have some induration. You're going to need a finger test, which we'll look at in a minute. Your zone 3, you're hoping is normal tissue, but you're going to take a biopsy from that anyway and send it to the lab. So this diagram just represents that, you know, your zone 1, you're going to take all the skin, but your fascial excision needs to include the whole of zone 2 and your 10 millimeters margin as well. So how do you know what it is? Well, you get this kind of grayish necrotic fascia. You have a lack of resistance to dissection. You have no bleeding. You have foul smelling liquid. And then there's this thing called a finger test, which I don't know if any of you have come across. It's supposed to identify the integrity of the dermal layer. You put your finger in and the fat in the dermal layer peel away from the muscle, and you get this kind of dishwasher smelly fluid. I've only seen it in the operating theatre. When I went to the course, apparently there were a few people that were making a 2-centimeter incision in the emergency department and trying this. I don't know whether that works or not. I don't know what other people's experience of it is. My personal opinion would be, if I was suspecting it, I'd probably go to theatre, to be honest. So here's a couple of cases. So this is a polymicrobial necrotizing fasciitis. This 56-year-old male who dropped something on his foot. He presents to emergency at 48 hours because he's got a sore foot. He gets treated as cellulitis and he's referred to orthopaedics at 72. He's an insulin-dependent diabetes. He's unwell. He's got a LRINEC score of 8. He's got tenderness over his anterior leg and thigh. That's his picture. And that's what he ended up with. So he went to theatre the same day. He had extensive debridement. He improved within 48 hours, extensive loss of skin and soft tissue. He had some back dressings put on and eventually had a rotational flap and skin graft within 2 weeks. This is another one. So I think in the first slide, I showed you another picture of this guy's finger. He's a 51-year-old who likes to drink. He's had a scratch from a rusty nail. That's his middle finger. Debridement 12 hours after presentation. It was debrided to the elbow, and at the time, his deltoid specimen was negative. 12 hours later, they grew something from his deltoid, and he had to go back to theatre and ended up with a 4-quarter amputation. Unfortunately, he developed toxic shock, DIC, and he actually died in the ICU within 12 hours of his second operation. So the point being is that a group A strep will give you a much more rapid progression. It can suppurate, it makes you more prone to bacteremia. Toxic shock syndrome is more common, and you get these endo and exotoxins which multiply the virulence of the organism. This is a clostridial infection, so it is one of the deepest of the necrotizing fasciitis infections, generally a bit more incubation. You've normally got trauma and a malodorous wound, but you get pain out of proportion, you get bullae, and then you get features of sepsis, which is fever and tachycardia, and your mortality is 25 to 100%, which we can talk about. So here is a 32-year-old IVDU. He's had a swollen left leg for 3 days. He comes into A&E, and he's unwell. He's got a temperature, he's a bit tachycardic, and he's got increased pain in the left leg and foot. He's tender to palpation. So what specific clinical features would you like to look for? Features of what would push you more towards a necrotizing fasciitis rather than a cellulitis are these, which is pain out of proportion, swelling in erythema, which is common, rapidly progressive cellulitis, tenderness beyond the area, indistinct margins. So he's got some of those. Would you like some investigations?
Yes, I will.
History already. He's got 3 days of pain. He's got no history of trauma. He's an IV drug user. But you're right. We're going to ask for some blood tests. So these are his blood tests, right? So if you look at his blood tests and then you look at his LRINEC score,
Yeah.
8. And as you said correctly, above 6, you'd be concerned. Now he's got 8.
Yeah.
So you were about to tell me what you were going to do next.
Yeah, it's
That was just a brief case, but in summary, this is a critical condition, and I think you have to do a WBA on it at some stage for your FRCS. The red flags to differentiate between cellulitis and necrotizing fasciitis would be pain out of proportion, hypertension, altered mental state, erythema progressing along the limb. That should say flatulence rather than fructuous, hemorrhagic bullae, necrosis. But at the end of the day, it's one of those conditions like compartment syndrome and fat embolism syndrome that you have to have a high index of suspicion to diagnose it and treat it appropriately. So that was my presentation. Any questions?
Well, that's brilliant, Nikki. Thank you very much. You covered this topic quite comprehensively. And I doubt it very much you need to know anything more than this to score top mark in the FRCS. So I think, guys, please take notes and remember everything said today. Just a few notes. I mean, you all guys know this is FRCS. If they show you soft tissue infection in the exam, they're not going to show, they want to discuss cellulitis with you. So you just have the hint and straight away move on to the serious stuff. So have high index of suspicion. They want to make sure you are safe. And these soft tissue infections are hot topics in the orthopedic, within the orthopedic community in the UK at the moment. It's very interesting to know that patients don't have to be immunocompromised. There are a subgroup of patients. They could be fit and well, and they could still develop serious soft tissue infection. And that's very also important for the exam because the examiner might present the question in this way to you. A very important, as Nikki said, MDT approach, and that's what very, very crucial step in answering any of these questions. MDT approach to this one. You're not going to deal with this one on your own. You get your intensivist on board straight away. You get the microbiology on board straight away. It's life-threatening condition. You might need to get the general surgeons if the cellulitis is, or or necrotizing fasciitis infection spreading through the perineum and abdomen or chest is very commonly. So it's MDT approach. And also they were gonna ask you about this LRINEC scoring system, because it's also a hot topic these days. And what Nikki said is very interesting, that it's not validated. It's not a validated score. So you could use it to help you confirm your diagnosis or confirm your suspicion. But if it is negative, it does not rule out necrotizing fasciitis, and you still have to rely on your clinical suspicion. Is that correct, Nikki?
Yeah, that's true. It's not a validated score.
Yeah.
It's more of a guide. I think they still say it's a clinical diagnosis, but I guess it helps guide you a little bit in that one of the cases they presented at the instructional course was, you have a patient with renal failure, elderly, with bilateral leg cellulitis that looks bad, but then their LRINEC score is something like 4. And you think, well, it's going to be a little bit more cellulitis than take this patient to theatre and start debriding her legs. So it's kind of a guide, but it's not validated.
Brilliant. That's very important. So I was just out of interest. So if we're going to investigate, even though you probably want to rush these patients to theatre, but if we're going to investigate, is this a CT scan and not an MRI scan, is it, or it doesn't matter?
No, I think that the general guidance is that it's a clinical diagnosis and you shouldn't delay any surgical debridement on the basis of waiting for investigations. So they didn't talk about MRI scans either at the BOA or the instructional course. Obviously, that would be something we could do if we weren't sure. But I think if we have someone that's acutely unwell with a severe soft tissue infection with an LRINEC score of above 8, I think we're going to be forced into debriding it and then doing imaging afterwards, to be fair.
And
I think that's fair enough, because I think NEC Fas is one of those conditions whereby they're going to die if you don't start antibiotics. So I think it would be fair enough to start the meropenem and clindamycin straight away. And then you do your tissue specimens in theatre, which hopefully won't be longer than 12 hours. But I think if you're thinking of somebody with necrotizing fasciitis, they may well have been treated with antibiotics as a cellulitis to start with, and then you're going to take them to theatre. I think if they're going septic, they absolutely need to have the antibiotics.
Brilliant. Of interest, while we are discussing this, it's a side topic. It's not really major, but we talk about, and you talked about applying vacuum dressing on these wounds. Yeah. I mean, that's really, we're going into tiny details here, but is there a limitation on how much surface area can you use a vacuum on? I mean, that picture you saw, can we put vacuum on all this? This is almost third of the patient or quarter of the patient. It's not easy, is it?
No, I think that's interesting for us because, I came from Australia where I was a big fan of vac dressings, even for, massive open wounds like that leg. But they have been shown to have increased blood loss. And although in the presentations, the guys used vac dressings, one of the comments they made afterwards was that they thought the vac dressings increased blood loss. So they were going for more saline soaked dressings at the end and then revisiting the wound in 12 hours.
Okay. And thank you very much. So, Abdullah and Kashif, any comments, please?
I think Nikki has covered very well. And definitely it's a clinical diagnosis, so you can't wait for many of the investigations. You need just basic blood investigations, which can be done quicker while patient is in A&E. Because I worked in plastics hand surgery unit for 9 months, and I've seen quite few, and patient usually deteriorates very rapidly. So as soon as you diagnose the patient, you need to rush to the theaters.
I agree. I mean, this was a very good presentation. You think you know about necrotizing fasciitis, but you learn something every day, and I've learned a lot from this presentation. This is a common, in practice, this is a common dilemma, because everyone is referred to us as necrotizing fasciitis, and 99% of them will turn out to be just cellulitis. That is in real life, and the exam, I think it'll be more clear cut. I don't think that they will present you with cellulitis, as Firas was saying. So if you see something like that, you have to mention necrotizing fasciitis, and they will then guide you whether they want you to talk about it or not.
We have, thank you, Abdullah. I think we have a question from Atif. They're saying that renal failure and diabetes can give false positives on LRINEC scoring system. Is that something that's sort of FRCS, could be FRCS question, or could be FRCS exam, or?
Yeah, I mean, I guess, you know, you can get false negatives with decompensated alcohol liver disease. And I guess if you can't mount a response, then your white cells and your CRP are not going to match the level of infection. But then that's why they say it's a clinical diagnosis. So we have to just be aware of that, I think.
I think I agree with you. I think we don't have to dwell too much on that. We just could exactly say we are aware of it. It's a scoring system that could help us in making decision, but diagnosis is mainly clinical, high index of suspicion, and stay safe. I think that's as far as this test goes. Yeah.
I think one of the key things to remember is this is a multidisciplinary approach. Often in this case, yes, there are plastics. If you're in a big teaching hospital where you have plastics and vascular, everyone is involved. But in the normal DGH, which is where the FRCS is based, for want of a better phrase, you are everything. So yes, this is something that we deal with on a regular basis. I think I had one. Well, I was referred as so we all will get someone who was, the medics were certain was definitely necrotizing fasciitis only a couple of weeks ago, and we both, my consultant and I both went really, but it is something that we are expected to do. So it is fair game for the FRCS. But yes, do mention a multidisciplinary approach, and yes, your plastic surgeons will be involved. But the last one I had to do a year now, which was proper neck fash, I had to do the above knee amputation. So you don't want your plastic surgeons doing that, do you now?
The other thing is, because the rapid progression of the disease, there will be no time to refer to the nearest plastic surgeon. Yeah. So you have to be able to recognize it and deal with it, and then leave the aftermath to the plastic surgeons to.
Yeah. The plastic surgeons are part of the team, but if it's involving the limb, we'll probably be leading the team as orthopods. So it is our sort of area. Really.
Decision, yeah.
It is tough decision, and it is one of those difficult cases to deal with on all levels. And sometimes if you take a patient to theater, you got to consent them for amputation. Remember that, very, very important. If the exam, they take you to, consent this patient, they might ask you, okay, here's the patient consent. Please remember you're consenting for possible amputation. And if you're doing that, you need to make sure you're including a senior surgeon in the decision making.
Yeah. Yes.
So these are all implications you got to cover in the exam to ensure you are a safe surgeon.
So yes. Remember, yes, it is something that where you have two consultant sort of point of view. It doesn't have to be orthopedic; it can be the anaesthetist as well.
Yeah, but it has to be consented for and documented. I mean, if you end up in a difficult situation doing, having to do amputation to save life, obviously that's defendable. But you just need to know how to back up your answer.
Yes.
If you're not aware of these issues, you'll be shocked when the examiner asks you. So at least have an answer to how you're gonna approach all of these scenarios. Any other comments from the mentors? Or happy? I think that was very nicely covered, Nikki. Really appreciate that your input in the group. It's a great addition, and we have to rely on our very generous mentors to keep this teaching program going. So thank you very much, Nikki, and thanks David, Kashif, Sahib, Abdullah for joining and supporting. So anyone wants a CBD certificate, please get in touch with me and I will send you one. And that will be the end of this session, if all happy. There will be a short Viva session afterwards, so anyone interested, please raise your hands and we'll get that started shortly.